Okay, so good afternoon, everyone. Thank you for your attendance. Do you hear me well? Good. So, as you just said, as you just said, my title is Medical Students' Emotional Experience in Early Clinical Traineeships, a model. I choose the term traineeships instead of internships because this is not about interns, this is not about residents, it's first year in medical school traineeships. And my work was directed by Michel Cunin. I won't give a too long introduction. The starting idea of my work is that we know very little about the emotional experience of these first traineeships. I mean, first year traineeships just after the first year of medical school. However, we suspect that this must have an influence on future doctor skills, especially communication and interpersonal skills. I only want to describe the first traineeships of our students in France. At the end of the first years, following the examination entrance contest, they will spend a month in a hospital in a so-called Introduction to Nursing Care traineeships. In fact, the content of this traineeship is very variable from one place to another. Then, for the next 2 years, that is second and third year of medical school, they will spend between a few hours to a few days in different hospital departments for a traineeship called Introduction to Hospital Function. That is exactly there that they should learn the basic of clinical examination, just as we've seen, but there is not examination, not assess until the 6 years of medicine. So they learn, but they don't have any clue of how to do that. Oh, sorry. So the purpose of this work is to measure the importance that emotional experience can have in these first traineeships and try to propose a modelization of it. I will show you what is modelization after. The research question was therefore, what is the emotional experience of second and third year medical students during their first clinical traineeships? And also, how do they perceive the management of their experience by their supervisors? So the method, it's a qualitative study that I conduct in Lille from 2016 for 4 years. It was a theoretical sampling, and I recruited only students in the second or third year of medicine. It was direct and snowball recruitment, I did both. And it was comprehensive interviews, that is not semi-guided interviews, really free interviews. I recorded them, I transcribed them entirely, and I used a grounded theory approach analysis that needed a lot of reports writing at all stages of my work. So that's a very time spending work. And developed a lot of labels. It's the coding work. And the aim was to have conceptual categories, not only thematical, but we're all trying to step up. And the production of a modelization that is a graphical representation of the interaction of the different concepts together. Let's see that immediately. To make my modelization clearer, I've made 3 different schemas, but at first it was one huge modelization. I only take you a moment to show you my informant chart. So I had 12 students recruited, and each time the interview lasts minimum of 1 hour. And in total, I have 17 hours of recording and verbatims. So we move on to the first scheme. On a time scale that goes from left to right, I artificially arranged 2 important stages concerning the student's emotional experience. First of all, I described the discovering care stages. This is a stage that is characterized by the importance of the first few times. The students will quickly be confronted with a whole series of events to which he was not or not very well prepared, and which will show him that the reality of the hospital is not the one that he was used to until now, his normal life. Sorry. And it is the relationship with the patient's body that will provoke the strongest emotions. I will explain why. In everyday life, we all know the social rules, the distance to be respected. But here in the hospital, the job of caregiver involves touching the body, seeing it naked, feeling it, sometimes even hurting it. And all this is usually forbidden in our social life. But for the job of caregiver, it is mandatory. Sometimes these transgressions could be a source of pleasure, but more often it's rather bad. What I mean by pleasure in transgression? Someone said to me, it's not every day that you can see such a beautiful wound like that. And bad things, another student told me, it's a little strange to think that we are cutting people up, to touch the integrity of the body. It's weird to come on someone, like touch their body without first talking to them, introduce yourself, ask them what their name is. I mean, you wouldn't do that with someone on the streets. It's the same here. Back to my schema. Some of the students will have trouble getting rid of the image they saw, and they will keep them for a long time in their mind. I will pass on the details, but I have an example of a student that tells me it drops in the basin, and no, even the word basins make me want to puke. Sorry. At this stage, it is important for them to have a protective supervisors. What I mean by protective, it's someone who reminds the students of his or her mission as a carer, rights and duties, because most of the time they don't have this information. If this goes well, this traineeship serves as a rite of passage, I don't know if it's correct, and the students can assume his new caregiver identity, is moving from normal one to I'm going to be a caregiver. This is a stage that is quite short and specific to these initiation courses. Paradoxically, to the importance of these first experiences is that they are quickly forgotten by the students. If we will ask them in the 4 or 5 years, they won't tell you that experiences. We move on to the second stage. It's artificially separate, actually, that happens at the same time. I called it dynamic experience. It starts from the first traineeships, but actually it will last throughout the whole career of the doctor. Here, it's the encounter with the patient life and history that will provoke the most diverse emotions. It is never insignificant to be confronted with death, illness, loneliness, poverty, old age, all these inevitable subjects when you work at the hospital. Sometimes it will resonate with students' intimate life. For example, we have a student that says to me, my biggest fear was not that he will die, but that he will die in my hands. That was what was terrible. I was afraid, actually, I think, to see a dead man. At this stage, the informant are already talking to me about the search for an empathic posture, even if for them it's difficult to explain what it is at that stage. We also have the very important questioning on the association of technique and relationship in the profession. This is already mentioned at the first year of the studies. They already think, oh, I'm going to do in medicine to associate those both concepts. The role of the supervisors is also very important. And here it needs to be empowering, not only protective. That is, to be able to exchange with the students, to facilitate questioning, but also to let him make mistakes, experiment himself, and guide him. They want more autonomy, but not alone. So back to the whole schemas, I've surrounded the whole courses with a framework that represents supervisors. The students here are not very sympathetic with their teachers. They describe 2 typical profiles among them. On the one hand, the official supervisors, those who are in charge of the training, most often they are described as absent, or who only provide information, that resembles that which can be obtained in class. What is the point of going on a traineeship, they tell me. On the other hand, we also have many people who will really provide them with great training in the sense of this protective and empowering supervision I've mentioned earlier. Quite everybody can be this informal trainer, from nurses to doctors, older students, even patients or health workers. In fact, there are people who are motivated to teach without having to do so. I have a quote to here from my students. The professor, he forbade us to see patients. How can you learn? Whereas every time someone explained something to me, it was the nurses. Let's move on to the second scheme. It's also based on the time axis. I will cut some of the results to say because I want you to have the key aspects. First, we see on the left, all students haven't the same background when they enter medicine. They aren't all equal in experience when they enter medicine. This result simply indicates that it is necessary to personalize the supervision during the traineeships. General information, for instance, cannot be adapted to everyone. I have example, I have students that explain me that during the whole infancy, whole childhood, she helped cure and wash people at Lourdes as volunteer engagement. And another student explained me that in his family, you're just not allowed to talk about emotion and illness. So both they came to the same traineeship, they have the same formation, they don't get to be the same doctors. Secondly, the most important part of this diagram is the heart. Students, they agree and even they say that it's very important to have a lot of experience. They want it to be repeated and very diverse. They want to meet different kinds of patients. They want to have a lot of traineeships actually. But what will really influence learning is the opportunity to have an exchange with a supervisor just after a real experience on both subjective and technical aspects. This is what makes it possible to transform an experience into an asset. They are really willing this kind of supervision. They say, not only to see a patient, I need to understand what I've just seen and what I've just felt. So I will go to the last schema. It's a little full, so I will zoom in as I go along. We see the center, it's emotions. The key idea here is that it's not the character positive or negative of an emotions that will influence learning. So if you have bad emotions, it's not necessarily bad for your learning. Actually, it's what we do with it that will change. If the emotion makes sense, it's recognized and accepted, it will lead to an investment in the training. Whereas if it remains misunderstood, it will lead to avoidance. And of course, avoidance prevents formations. I mean, you can't be sad because you've seen a corpse, somebody, and if you talk to it with your supervisors, it will, okay, so I'm sad because I want to cure people, and they invest. Whereas you can be happy if you do some blood test and nobody tells you that's great and you won't do it again. No, I'm lost. Yeah, I have an example. Students tells me the importance of understanding. It finally made it possible to put a word on all these emotions that I could feel and which were, I think, exacerbated. In fact, what makes me feel better, putting words on what you feel, allows you to become aware of what you feel, whereas before it was just a state. So now we'll see right away what can influence the meaning to give to emotions. I distinguished 3 factors that were protective and motors. First, the humanist values. It can be of the student himself or of his supervisors. It were a source of commitment. They often allow the student to assert himself and overcome the challenges. For example, we have the student who says, it means that you have the opportunity to practice medicine by being like that, being human. There is this possibility, so it's up to me later to look into it. Then we have scientific curiosity. The desire to learn, to understand and master was also very much represented among my informants. This is typically the one who said, what helps you to take it upon yourself? We say to ourselves, come on, it's an interesting clinical case to study, that's it. So I turn drama into something interesting if you want. And then what I called relationship adjuvant, like adjuvant treatment. Establishing relationship, exchanging with patients, relatives, peers, or supervisors was systematically associated with a positive experience. Put into perspective, the experiences were better understood and accepted. I have an example. Someone who said me, the concrete case is a case when I was talking about my dissection with my friends who helped me through this. On the other hand, we have everything that can hinder the emotional experience. I called it the toxic working environment. We have, for example, endemic transparency, as it's most evident from the interviews. I will just read you all the quotation paragraph. The numerous times we arrived at the traineeship and they tell us, what are you doing here? They don't know even that we are coming. It's a scourge when they're still supposed to take care of us. Or, I would have liked to talk about it, but I have the impression that everyone will not have time to waste with discussions like this with people like me, students. Or, I felt a little useless. Or, we were there and we were like a plant. Or, like a flower pot, truly invisible. I have too much. We also have common assaults. They can come from colleagues, but also from patients. And it is very difficult to talk about it in general. They just keep it to themselves. I won't give you all the quotes. It's pretty well summed up by, I learn in the blood, so she has to learn in the blood too. Or, they're not even controlled. We can't tell them anything. So in the end, they have all the power over us. Finally, the contagious moods. I refer to this tendency that caregivers may have to transmit their own anxieties or depression to students. One student explained it very well. I was afraid of her, but I wasn't afraid of her at first. It's just a fear that was induced because I was told, be careful, she can be very aggressive. And all of a sudden, at the end, it makes you afraid. Fear is not necessarily innate. It can be something you learn. Of course, most of the time, we overcome the challenges and it goes well. And people are happy to go and work and study medicine. So I suggest we move on to discussion. There is an abundant literature about suffering and of caregivers, but not of students, even more for youngsters students. It is an active research subject and many educational tracks are proposed. We have found experiments with cinema, theater, literature, and also exchange groups. In Holland, a study was done with the same question and a similar method as mine. It had results from another point of view, but complementary to mine. They emphasize the role of the faculty in the supervision of these traineeships. And they have the same difficulty as we do in offering instruction about this emotional experience. Strengths and limitations. I wrote the article following all the quality criteria of the correct grid, especially validation of the verbatims by informants after transcribing them, and validation of the results by informants. I exchange a lot with them about that. The three other points can be strengths and limitations depending on the point of view. We don't know exactly why this student accepted to enter my work. I didn't have any student not willing to do it, so I don't know if it's a difference. As it's comprehensive interview, to my point of view, it's helped a lot having emotional experience from the students, but it's a free grid and it's evolving a lot. So there is no reproducibility actually of my interview grid. And it's a subjective analysis strengths because we can find more specific detail, limitation because it can be different if you repeat this study. Conclusion. The emotional experience during the traineeship is very rich and intense. It is rarely taken into account and does not find its expected place in development of professional skills. Organized supervision seems deficient. Informal training exists when a volunteer student meets a dedicated teacher. The possibility of experiencing strong emotions in a protective environment and then testing them in an empowering environment is welcomed by students, as well, and especially early exchanges on the experiences of the traineeship, both about the subjective and technical aspects. I've proposed different interventions. Actually, each intervention is one of my categories linked to literature. So trauma prevention and detection of malaise in the workplace, teaching humanistic value, it's not part actually of our curriculum, and new pedagogical tools, just like cinema, theater, literature, writing, all of that already exists in some university. And other like exchange groups, companionships, solidarity commitments, that is not only in medicine, but in others, it helps with understanding the other. Immersive and tutored traineeships, and obviously training the supervisors. Thank you for listening.